Hi, I'm Helen Bauer, and this is the Heart of Hospice Podcast. The Heart of Hospice Podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This special episode of the Heart of Hospice Podcast, in collaboration with Stanford Health Care, is being sponsored by Kensington Senior Living. Kensington has senior communities in California, Virginia, New York, and Maryland, bringing the highest quality senior care to America's most sought-after locations. Kensington focuses on relationship-based care, built on the foundation of their promise to love and care for your family as they do their own. Visit KensingtonSeniorLiving.com for more information. This episode of The Heart of Hospice is being sponsored by Care Boss, the latest book by Jennifer O'Brien. Care Boss is the book that reminds family caregivers that they are the CEO of their loved one's care. Jennifer has served in healthcare leadership for over 35 years and was also the personal caregiver for her parents and her husband. Care Boss is written to empower caregivers, but it's more than just a book. It's a workbook and organizational tool as well. Check it out at jenniferaobrien.com.
In this first episode of our special series with Stanford Health Care, my guests are teaching me about palliative care, when to start it, and how it's different from hospice. I've got two fantastic guests today, Dr. Grant Smith and Emily Linderman. Grant Smith is a clinical associate professor of medicine at the Stanford University School of Medicine. He's an attending on the inpatient palliative care consult service at Stanford Hospital, and he sees patients in the outpatient palliative care clinic in Palo Alto. Outside of his clinical duties, Grant is the medical director for the Stanford Palliative Care Community Partnerships Team, which is providing public-facing education about palliative care. Emily Linderman is a board-certified chaplain, a spiritual care provider on the inpatient palliative care team at Stanford Health Care. She is dedicated and passionate about facilitating conversations about the things that matter most and teaching others how to do the same. And that's exactly what she was doing today during our conversation. You're going to hear us talk about the differences between hospice and palliative care. Grant's going to provide some details for that. Emily shared how there are misunderstandings about palliative care even inside the healthcare community, and what palliative care can actually provide to patients and families. They're also going to be talking about the roles that they play as a physician and chaplain on a palliative care team. And Emily explained how chaplains can care for patients who are non-religious or non-theistic. Grant gave a great explanation about how to know whether palliative care is the best option, whether it's the right option and when is the best time to use it. And they both also define how a transdisciplinary team works to benefit the patient. So there's a lot to learn in this conversation. And it's great. You can tell they're passionate, very knowledgeable, and I learned a lot about palliative care myself. So stick with me for this conversation. It's going to be a great interview. Grant and Emily, welcome to the Heart of Hospice podcast. It's great to have you with me.
Thank you so much for having us.
It's great to be here.
I'm so glad to have you. It's going to be a great conversation. We've got a multidisciplinary team going on right here just with us, so we've got a lot to learn here. We're going to start with an icebreaker question that I do with all of my guests. Lately, I've been using the End of Life deck, which is the sister game to the Death deck. It's a great way to start end-of-life conversations. So here we go. Grant, we're going to start with you. I'm going to put you on the spot a little bit.
Okay.
Would there be differences in how your family members would treat your medical condition if you couldn't speak for yourself? So there are three possible answers. A is no, I've been very clear with instructions. B, they would argue but ultimately agree. Or C, yes, they would have differences because they struggle even to choose a restaurant.
It is true that my family would struggle to choose a restaurant. I remember that my brother and I, when we were trying to maybe pick a restaurant, we would do like an elimination. We'd have like 5 places, and then we'd go back and forth eliminating one until one was chosen. So, but we had a method for making decisions, so that was good.
Oh, my word.
But to answer your original question, I would say that I have tried to be pretty upfront with my family in the way that I encourage my patients to be upfront, which is telling them what are the parts of my life that are most dear and valuable to me, and the things that I wouldn't want sort of my body to be kept alive if I couldn't do some of those things. So for me, that's really recognizing, interacting with friends and family. So I've been very clear about that being like a core value I would want them to hold on to. And we know it's hard to predict every situation, but I sort of trust that with that core value in mind, they'd be able to figure out what to do.
Yeah. If you didn't have explicit instructions, they could remember who you were, what you valued, and what your beliefs were. I like it. Okay, Emily, would there be differences in how your family members would treat your medical condition if you couldn't speak for yourself? So A is no, you've been clear. B, they would argue but ultimately agree. Or C, they would drive around looking for the restaurant because they can't agree on anything.
I think it's a combo of 1 and 2, and I think they would laugh quite a bit about how clear I have been.
Really?
Yes.
They would say, oh, I remember when she told us she didn't want that.
Yeah. They have copies of my advanced healthcare directive, and I sort of kind of like shock them. Maybe they would prefer me to be a little softer. So I think
I'm really tempted to ask you for an example of that. Please.
Let me see.
I think working in healthcare makes that kind of conversation very normal for us. But other people look at you and they're like, I don't even know what you're talking about. That thought never even occurred to me.
Yeah. I think I do feel just very clear, having spent so much time in the hospital, about maybe we can't always be in control of what kind of interventions happen, but how long I would want them to go on. And similar to what Grant said, what things are so important to me, like being able to communicate, that I wouldn't want to live without that ability.
Yeah. I love that question because it really gets us deep into advanced care planning, which is part of hospice and palliative care all the time. Yeah. And that's going to be our focus today. We're talking about basically palliative care versus hospice care, not adversarial, but a comparison of what they look like, how they're similar, when they can be utilized. And you guys are the experts in this. So I'm looking forward to really picking your brains about this. So we're going to start off with a question for you, Grant. What are the big differences between palliative care and hospice care?
Yeah, I think one of the first things that comes to mind is actually a difference in people's awareness of palliative care. that is such a thing that exists, what that word means. We know that actually about 70% of adults in the US have never heard the word, so it means nothing to them. And probably about over half of people who say they've heard of palliative care, if they were trying to describe it, would include something that's not accurate about palliative care. So we know that there's a lack of awareness and a lot of misunderstanding about palliative care. And I do think that's an area that's a little bit different than hospice. There certainly can be misunderstandings about both of these concepts, and they're
Sure.
related. So we're really thrilled to be here today to try to help clear that up a bit. Palliative care, the goal really is to try to improve quality of life for individuals. The word palliative comes from the word to palliate, which is to alleviate or try to mitigate. And that's really the goal, is to try to alleviate suffering, to alleviate difficult or burdensome symptoms. Palliative care, I think when we're talking about it today, another good distinction is that we are really talking today about specialty palliative care, which is specialized medical care provided by a team of healthcare professionals. I'm one of the doctors on our palliative care team. Emily is one of the spiritual care providers, but we also work with nurses, social workers, advanced practice providers, and it's really specialized medical care. As I sort of said before, our aim is to improve quality of life, and that's really through trying to help manage difficult symptoms, and those can be physical symptoms, but also helping to care for emotional, psychological, spiritual, or practical issues. And that's one of the reasons we work with an interdisciplinary team. And I'd say that that's an area where hospice and palliative care are somewhat similar, the goal of focusing on quality of life. Palliative care, I think, should really be thought of as an extra layer of support that can be provided in addition to someone's other medical care. So I think an important difference here is that you really don't give up anything to see a palliative care team. And that's where there sometimes is a difference for hospice, where hospice as an insurance benefit, there might be limitations to the treatments that might be covered or available for an underlying illness. But in palliative care, you really can get any treatment that your other doctors are offering or providing. And also, as kind of an extra layer of support, you still have your other medical providers, your primary care doctor, your cancer or oncology doctor, your heart or cardiology doctor. So we are an extra added team that's there to provide extra support. It's not necessarily a big transition in the overall goals of your care.
I think that's one of the biggest misunderstandings or misnomers, if that's the right word, about palliative care. I think so many people think that because quality of life support is hospice, that palliative care is the same thing. And palliative care as a specialty is sort of the new kid on the block, isn't it? It hasn't really been around that long.
Somewhat like hospice, in the world, this type of care has been around since the beginning of time,
Yeah,
but
centuries.
as a medical specialty, it is relatively new.
I think around 20 years.
Yeah, that in the medical world, that's very young. Truly is. So just as an example, Grant, so if somebody was receiving treatment, say an end-stage renal failure, chronic renal failure, a kidney patient who's receiving dialysis 3 days a week, seeing their nephrologist, palliative care would not be added on in place of what they're doing. It would be added into what they're doing to give additional support.
Exactly right, Helen, that we would be there to help support that individual. Maybe they're having some symptoms from their chronic kidney disease, or maybe dialysis is presenting some unique challenges that they're working through, whether those are physical symptoms like fatigue, or maybe the burden of going to dialysis or getting dialysis is starting to really push up against that balance of burden versus benefit. Our team would be there to talk with that individual about how they're weighing those risks or burdens versus those benefits and thinking about what's the best care plan for them moving forward. But absolutely, they would still be able to get dialysis, to still see their nephrologist, and come get that extra support from a palliative care team.
Well, and for instance, if they were having trouble with transport to dialysis, actually who's going to drive them, how to get there, you've got social workers on a palliative care team that can help with the more practical aspects of their health care, right?
That's right. That's part of that interdisciplinary teamwork that we really aim for. I also think, Helen, another little turn of phrase that I like to use when thinking about this aspect of palliative care is that palliative care can be appropriate at any age or at any stage of a difficult illness. And I think just that quick turn of phrase can be really helpful for people who are still struggling to know, is it right for me? It really can be available at any age or any stage of an illness. And I think we shine when a difficult illness is starting to impact those different aspects of life that we can help out with. So if someone has physical symptoms and that's starting to cause psychological or emotional stress or spiritual concerns where they're wondering about why that's happening to them or how that fits into their spiritual conception of the world, I think our team can shine in supporting that individual through our interdisciplinary team.
Absolutely. So I think that even healthcare workers don't really know what palliative care does. So I've been a hospice nurse for 15 years, palliative care being newer, and I have not worked for a hospice agency that actually had a palliative care program, just through the way my career moved. So I have not worked in that myself. I think there are a lot of healthcare workers out there, clinicians even, who don't really understand when to put palliative care in and how it can be added in to provide that extra layer of support. What are some of the myths about palliative care that healthcare workers have?
Maybe I can start, or Emily, you want to start and I can go next?
Sure. I just wanted to underscore what Grant said earlier, that even healthcare workers benefit from the reminder that palliative care can be provided at any age and stage of serious illness. I think if that could become a mantra throughout the healthcare system, that would open up access for so many patients and families. And palliative care isn't about giving up. We're about keeping going in pursuit, the interdisciplinary pursuit of quality of life, as B.J. Miller says. And so that is a thing that healthcare workers can also benefit from learning from. I didn't know what palliative care was when I started my training as a chaplain. I didn't understand that we weren't just focused on alleviating pain or helping people with the end of life, that really it can start, that extra layer of support can start so much earlier, and we can follow people for years. And sometimes that's one of the biggest gifts of our work, is being able to develop longitudinal relationships with people and get to know them as their values and their priorities change over time.
Well, and isn't that amazing? Because we talk a lot in the U.S. about a continuum of care in the healthcare system. Anybody who has engaged with the healthcare system will tell you it's very siloed. There are drops. It's supposed to be transfers, but information is lost. Medical mistakes are made because of those handoffs. There's nothing continuous or continual about it. It's very much fits and starts. So to have a medical specialty like palliative care that could actually follow you through, be a little bit of an anchor, a foundation, along with all the other specialties, that's such an advantage. But healthcare workers, I think, even my age, I've been doing this, I've been in nursing for over 34 years. I don't think we know when to utilize it. So what do you think healthcare workers' perception and understanding of palliative care is, Emily?
Well, what I am sometimes surprised to hear, yesterday I was meeting with an infectious disease expert. We were in a family meeting. And to your point, understanding that palliative care, one of our greatest gifts is the ability to coordinate care and to understand, wow, we are having siloed conversations. And it seems like the biggest way that we could support a family and patients, and also other providers, because it's really hard on other providers too, is to call us together into the same room. And I loved hearing from this infectious disease expert, I love palliative care. And I was surprised to hear that.
Oh, he actually said, I love palliative care?
Yeah, we were having a pre-meeting. And so healthcare workers understanding that that's one of our gifts. And that's one of the things that we train in, is being able to see, wow, we need multiple people together. And sometimes we need to get together and talk to each other before we meet with a patient and family. So healthcare workers, I think nurses are really, really good and kind of the undersung heroes of recognizing when communication is really needed. Like when a patient and their family have a lot of questions that other healthcare workers think have been answered or addressed, maybe in bedside rounds, but they need something different. They need something that is more than just a standing meeting. One of our goals is to sit down in every room. And so healthcare workers know when they see us with our stools around the hospital, that we take time. So I would say those are some of the conceptions that we're looking to retrain with people.
Nice. Yeah. So with an interdisciplinary or a multidisciplinary approach, you have all these different experts in their own areas that bring their skills and talents to the care of the patient and the family. Grant, when it comes to the physician who is on the palliative care team, what is the role of the physician on that team?
I think we have special expertise in a few different areas. The first being trying to manage those difficult or burdensome physical symptoms, both in trying to help with non-pharmacological interventions that may help, but also we have a lot of expertise in managing medications for different symptoms, whether that's pain or nausea, shortness of breath, even constipation. That can be really bothersome. So we try to help manage with both non-pharmacological and medications. I think the other main role that we play as physicians is to leverage our experience seeing disease and illness trajectories and helping counsel patients on what to expect for the future or what possibilities there may be looking ahead. And I think that can take the form of anticipatory guidance, providing reassurance. There are going to be some ups and downs as you go through this chemotherapy, but we're going to be there to help support your symptoms and we'll walk alongside you across this journey. 2, thinking about, gosh, I really hope that things work as well as we're all planning for. But if they don't, I wonder if we should sort of think about a plan B. And that can be our role in helping with what's called advanced care planning that we mentioned a little bit earlier. So I think that management of physical symptoms, helping with looking ahead can be really helpful. As Emily said, care coordination. I spend a lot of time emailing and talking to other doctors about, hey, I just want to make sure we have a really good care plan. Could you help me understand what's the path forward for this individual? And with that, I think can go along some advocacy for patients. So sometimes a patient will tell me, Doc, I really don't quite understand what's happening with my illness or what the last CT scan showed. And I think there is something about that physician-to-physician communication that sometimes I can ask a question for a patient and get an answer that maybe they couldn't quite get when they were advocating for themselves. And so I think that's another really important role I can play as a physician.
Yeah, which is very important because discipline to discipline and specialty to specialty communication doesn't always happen the way it should. Yeah. So to have that sort of liaison and advocate is very valuable. I am loving this conversation, but we're going to take a break right now. There's more to come.
The Heart of Hospice podcast is proud to partner with Stanford Health Care to bring you this special 4-part series sponsored by Kensington Senior Living. Kensington focuses on relationship-based care built on the foundation of their promise to love and care for your family as they do their own. With communities in Northern and Southern California, Virginia, New York, and Maryland, they're working to provide the most loving and expert care in a comfortable setting, bringing the highest quality senior care to America's most sought-after locations. Caregiver Susan Evans shares how a move to a Kensington facility affected her family.
I was first introduced to Kensington in 2015. Our family made the difficult decision to move my father to Kensington in Northern California. Moving my father to Kensington was the best decision and hardest I have ever made. My father was happier, more content, and definitely less agitated. Kensington Senior Living gave my parents their relationship back and gave me the quality time back with both my mother and father.
Kensington weaves heartfelt professional care into the everyday lives of residents. They offer a wide range of services and amenities so residents can live securely, unburdened, and well attended in a beautiful community they're pleased to call home. For more information, visit kensingtonseniorliving.com. This episode of The Heart of Hospice is being sponsored by CareBoss, the latest book by Jennifer O'Brien. Jennifer O'Brien has served in healthcare leadership for over 35 years and was also the personal caregiver for her parents and her husband, Dr. Bob Limberg. She is the author of The Hospice Doctor's Widow, an art journal of caregiving and grief. CareBoss is her latest book, and it's more than just a book. It's a workbook and organizer that enables family caregivers to lead their loved ones' care sensitively and effectively. Jennifer writes with compassion and hard-earned wisdom, and readers will appreciate the empowerment and camaraderie they find in the pages of CareBoss. CareBoss reminds family caregivers that they are the CEO of their loved one's care. You can find CareBoss at your local indie bookstore or on Amazon and on Jennifer's personal website at jenniferaobrien.com.
Okay, Emily, how about you guys? Chaplains or spiritual counselors, what's their role on the palliative care team?
I'd say we have a couple roles. One's very specific, and that's paying attention to the spiritual, religious, and existential aspects of being human, and specifically in a serious illness context. So I have an assumption that everyone has an inner world. And so regardless of whether or not somebody has a religious upbringing or a religious affiliation, everyone has an existence that causes them to question, that causes them to reflect, to wonder, what's going on? How is my life going to be changed? Or my life has been impacted by this. And so when I meet with somebody, I'm interacting with them human to human. How have they been impacted as a person in the context of serious illness? How have their relationships been impacted? How has their sense of meaning and purpose been impacted? So we're really listeners who are tuning in to how the human has been impacted, the person in front of us, and their network of relationships and understandings of who they are and how they are now.
There's a lot of misconception out there about the role of the chaplain.
Yes.
Spiritual counselor. People don't understand what a chaplain does, what they can bring to that relationship between the patient and the chaplain, and how they support the caregiver as well. In hospice, obviously, we do that. We have perpetuated, I think, the myth that it is the chaplain's role to convert, judge, proselytize, save, redeem, all of these things, to witness. And in the more conservative parts of the United States, that is the kind of chaplaincy that is practiced. It is not the appropriate kind. That's not the true role of a chaplain, right? What would you want patients and families, speaking to lay people, consumers who are in there, what would you want them to know about the care that you provide?
That it's for everyone and that it's not about me. Like any chaplain has some sort of, I don't even want to call it a faith background, but might have a religious background or a spiritual orientation that grounds us in the work, that allows us to keep showing up in the face of suffering. But that's where it should end, with as far as if a patient or a family wants to know what has shaped me in this work, I'm happy to answer that question, but it's not my job to share that with them. I am in service of their spirituality. I am in service of their existence, to use that word about their existential realities. And it's actually against my code of ethics. When I became a board certified chaplain and I agreed to do this work, it is against my ethics to proselytize or to try to get anyone else to believe the way I do or to not believe the way I don't believe. And so I would hope people would know I'm there to listen to the heart of the matter and what makes this situation feel unbearable, and also what gives them strength, and to help them reflect on the resources they have within them and outside of them during this time.
That's beautifully said. I love that. I really do think chaplains get a bad rap. I know a lot of hospice patients not understanding the role of the chaplain or what they're going to be doing will refuse those visits because they're just not sure of what goes on.
We've earned that reputation. We earned that reputation for a long time. And so I try to be humble in the face of knowing that that reputation precedes us for a reason. And so I hope, and I feel like it has changed, in my experience is that being in a healthcare context and interacting with different healthcare providers, patients, and family members, we can change that reputation through our behavior, but that's the only way it's going to happen, is if we show up and do things differently with more humility, with more love, and more skill, to have our training be about something different.
Yeah. And for listeners that are caregivers, anybody who's not working in the healthcare system and hearing this information, I think it's really valuable. Chaplains or listeners, they come in with the patient's needs first and foremost in their minds. Super important. So some of the patients that we see are not affiliated with any religious beliefs. We serve agnostic, we serve non-theistic, atheistic, we serve humanist patients. How do you, as a chaplain, provide care for someone like that who will tell you, I don't have any belief in an afterlife or a higher power? How do you provide care for someone like that?
If this was recorded, you could see me smiling right now, because those are some of my favorite visits. And if I'm honest, I have all of those different parts in me. So that's another reason why I like this work, is that my spiritual sensibilities and understandings of the world in the face of beauty and suffering change all the time. So I feel like I can go in and be very curious about what's going on with someone. And I'm thinking of a patient in particular that saw my big yellow spiritual care badge, and I was walking through to meet his neighbor, and he waved at me and said hello and said, "Looks like you're religious. I'm not." And I said, "Awesome." And
that was his first assumption, was you were religious. Yeah.
And he said, "I'm not, but it's okay that you are." And so on the way back, I, stopped to say hi to him. And I said, "It sounds like you're, not religious, and that's okay with me. And it sounds like you already know that." And we ended up forming a relationship where I met his family, and we met several times. And he was a younger person. He came to the end of his life outside of the hospital, but he came up with his own sign of the cross. So in the name of science, medicine, and technology. So I got to know, and that was a joke. He had been raised Catholic, but left it behind. And I asked him what was most important to him. And he said these things. He had a very clear plan. He had a very financial plan. So I listened to what was most important to him, who was most important to him, how it was to be making these healthcare decisions. And then I helped him with some legacy things. He was really committed to trying everything to survive. Survival was his number one goal. But he was so honest that it wasn't guaranteed. And so in the context of that, he was doing everything he could to be practically prepared to care for his family. And because of our connection and the trust that we developed over some visits, I accompanied him as he attended to some personal legacy projects, not just the practical, recording videos for his children, recording videos for his wife, and then being with him when he was grieving how much he loved these people.
Yeah.
And also, he requested that I talk to his doctors if he died. And he asked me if he didn't make it, would I tell his doctors on his primary team that it was worth it to him to do all of this? And he didn't blame anybody.
So he was asking you to help with the grief support for the other providers that had been caring for him?
Yeah, he
Wow.
was so thoughtful about how his death might impact the people who had tried so hard to help him survive. And he wanted them to know it was worth it to him. Even if he didn't make it, he really hoped it would benefit somebody else.
That's an amazing point of view from a patient.
Yeah. And what a privilege as a chaplain to be in that space where that had nothing to do with a religious orientation or any kind of sacrament, but he did have rituals and practices that he did to create expressions of love, which, I mean, that's the best part of my work, is being a witness to how people love each other, but also encouraging people to be maybe a little bit more brave. You know, it broke his heart to think about making those videos, but when he did it filled him with a sense of strength, knowing that those were available to his loved ones in the future.
It takes a lot of courage to create legacy projects because it is very forward-facing into your own anticipatory grief.
It is.
Yeah.
It is.
Yeah. That's an amazing privilege to be able to participate as a chaplain, to be able to do that. So, Grant, let's switch gears just a little bit. So when it comes to making decisions, palliative care, hospice care, with someone who has a serious illness, an advancing illness, how does someone even decide which type of care is appropriate for them?
Yeah, I think this is such a good question, and I think it is sometimes a challenge for patients living with a serious illness. And I think in general, I'd recommend that someone reflects on their goals and values and sometimes has to really wrestle with what could be conflicting values. And I think in my experience, what I see is that a lot of people hold two values I think we all have. I want to have a good quality of life and that every day is as good as it possibly can be. And I also want to live as long as possible and do everything I can to have more time and have more days. And I'd say that most of medical care, fortunately, we're getting both of those things. That getting more treatment helps you live longer, helps you feel better. But sometimes with a serious or difficult illness, those two values can start to come in conflict a bit. We use kind of chemotherapy maybe as an example. You know, getting more chemotherapy may help you to live longer, but it may mean that the days that you have are dealing with more side effects. Stopping chemotherapy might mean that the days have fewer side effects, but it's possible that there could be fewer of them without that treatment. So I think that making a decision about if hospice is right for you, I generally advise my patients, I think hospice is a good fit when you really care about each day being as good as it can be, and you're a little bit less focused on doing everything under the sun to have more of those days. I think palliative care can be a really good fit. One, if you're still asking that question, you're not sure what care is right for you. That's a big role that we play, is helping to figure out and wrestle with that question and think about the benefits versus the burdens of different treatment options. Palliative care definitely can support someone like we've talked about, any age or any stage of an illness, and whatever treatment you're getting, we certainly support that. And we're just that extra added support. So we're a good home for patients who know that they want to continue pursuing treatments of their underlying illness. So that's how I would sort of recommend to patients to start to wrestle with that question.
Yeah, it's a quality versus quantity question. And the way you phrase it is, I think, really easy to understand. So out of everything we've already talked about, the things that have already stuck in my mind is with palliative care, you don't give anything up. You don't have to forego treatment. You don't have to give anything up. And it's great for any age, any stage. Yeah, see, I'm already learning. Yeah.
This is great. You passed the quiz.
Listen, it's much more simple if you it's much more understandable if you just look at it that way. I think we tend to overcomplicate it, right? Healthcare people want to tell you all the different nuances and all the different philosophies. But in reality, consumers, people who are having to make these decisions, they don't need all that extra stuff. And more than likely, they don't have the space for it inside the situation in which they're living.
Can I add something to
Please.
I think that's one of the roles of the chaplains and the social workers on the team, is the same way that Grant talked earlier about being able to talk medical provider to medical provider, is that chaplains and social workers, we bridge. We're in the medical field, but we're not medical providers. And so oftentimes when it gets really complicated and I'm in a room with a patient and a family, I can say, I don't understand what we're talking about right now. And I wonder if you could, try rephrasing it in a way, or I'll summarize it to see if I understand what's going on. But I'm often trying to put myself in the place of the patient and family and advocate for a simpler message, and advocate for, say, if I can't understand it, and I've been working in the healthcare industry for years, then it's likely a patient and a family member can't understand it. And so then I'm trained to be in those situations and ask for the communication to be different.
And what a great way to advocate. Very simple, very subtle.
Yeah.
Can you clarify that? This is a little deeper and more complex than I can understand. Can you clarify it?
Yeah.
That's perfect. Very subtle, very respectful, very respectful. I love the idea of social workers and chaplains providing this bridging care, especially when it comes to family conferences, because let's face it, those meetings can get really crazy. A lot of dynamics. And then you layer in grief and maybe a sense of urgency for someone who's had an acute event, or family dynamics that go back 40 years that had nothing to do with the illness, but everybody's carrying it into this situation, or the relationships are so fractured that really nobody wants to be in the room to begin with. Yeah, you guys are the negotiators and the diplomats and the ones who bring us together and remind us that we share a common goal. We're all looking for the best solutions, the best plan of care, like Grant was saying. What's the best plan of care for this patient? So without chaplains and social workers, sometimes I think we'd all just smack each other in the conference room and nothing would ever get done. You guys are our negotiators who keep us from getting super cranky with everything. So Grant, we're almost through with our time, but I want to ask, so for people who need information about palliative care, what resources are out there? I'm hoping that this podcast and the Stanford series that we're doing is a resource for folks who are trying to discern and decide, but what resources are out there for people who need more information about the comparison between palliative care and hospice care?
There are two websites that I think are pretty good from professional organizations that are focused and patient, family, caregiver facing. The first is caringinfo.org, and the second is getpalliativecare.org.
Oh, that's an easy one. Getpalliativecare.org.
Yeah, one of the things I really like about getpalliativecare.org is that it actually has a provider directory. So if you listen to this podcast, you're thinking, hey, I actually would really like to connect to a palliative care team, you can put in your zip code and search for hospital, office, and home-based palliative care services in your geographic area, and it has contact information. So I think that's a great resource just to see what's in your local area.
I did not know that was out there. That's awesome.
The other thing to remember too is you can talk to your medical teams about palliative care. I think we've recognized today that there are still some knowledge gaps for healthcare professionals. We're working on closing those, but this audience is now armed with more accurate information about what palliative care is. So if you think that's something that could be helpful for you, I would encourage folks to go to your primary care doctor, your oncologist, your cardiologist, say, hey, I know what palliative care is. I'd like to talk with them. I think I'd like to meet with them. And Helen, to get a little bit at your question too about like when's the right time for palliative care, I sort of advocate that both patients and other healthcare professionals don't stress too much about that question. You can send someone and refer someone to our team, and we can help sort out like how involved we need to be. Sometimes we do a one-time consult, and sometimes, like Emily said, we might follow someone for years. We can help sort that out. So I would just sort of advocate that patients and caregivers should feel empowered to talk to their doctors and other healthcare teams about this service if they think it's helpful, and don't stress too much if it's the exact right time. We can sort that out through our conversations.
That's brilliant. I like that. Let the people who are experts in the palliative care decide whether this is a good fit at this time. I like that. So, Emily, one last question for you. What is the one thing we didn't talk about when it comes to the role of the chaplain and palliative care teams that you would want to have talked about today?
Our role as palliative care providers. So thank you so much for asking that question. We can facilitate family meetings. We can go and do the introductions to palliative care. We are a team that's made up of multiple specialties, but there's an overarching specialty of which we are a part. And I think that's really important to lift up, that chaplains and social workers, in addition to APPs and advanced practice providers and doctors, really function at this place where we can facilitate conversations, coordinate care with other teams, in addition to our specialty in the spiritual, religious, and existential domain.
Grant, you wanted to add something?
Well, I just want to add too, one of the things I love about practicing in palliative care is that we sometimes refer to it actually as transdisciplinary care, with the idea that as a physician, I should have some basic skills for how to evaluate if someone is experiencing existential, spiritual distress. And Emily, I know, can do a basic assessment of, does this person have uncontrolled physical symptoms? And we can tag each other in to meet those needs. So I just want to say that both my role as a physician is broader than just the physical symptoms. Emily's role as a spiritual care provider is broader than just the spiritual existential. We are sort of all responsible for all the domains. And I love that about our team.
You know, I was trained that every person on the team is responsible for assessing pain, which sounds a little bit crazy, right? Because, you know, we have CNAs, we have aides that go in and help with personal care, and you wouldn't think, well, that's not really in their lane. That's not in their skill set. It absolutely is, because the first thing, more than likely, that you're going to ask when you go in to make a visit is, how are you feeling today? Are you having any pain? And there is more than one type of pain. Dame Cicely Saunders taught us that. There's spiritual, physical, psychosocial, emotional, and everybody can ask those questions. And that really is the beauty of the structure of a transdisciplinary team. It's amazing. You guys did such a great job. I'm so happy to have you on the show as part of this series from Stanford Health Care. Thank you for educating me, educating my listeners, and you guys are just great. Thank you so much.
Thank you for having us.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes, and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.